Trouble with fat. So now we actually are going to get into something a little more practical, which is fatty tumors. This is the most common thing that all of you will see in soft tissue. So this is a less esoteric topic. How to handle the most common fatty tumors. Oh, yeah, this is where I work. This is the main entrance of the Cleveland Clinic. This whole hospital, which is only about 10 years old, this is just for cardiac care, which is kind of the driving force of the Cleveland Clinic is cardiology and cardiac surgery. And this is like a 500-bed hospital just for cardiac patients. And they don't even generate specimens for us, really. So, I mean, that's kind of unbelievable. Okay, let's talk about a little bit about the WHO classification of fatty tumors. These are the benign lipomatous tumors, and it's true that the vast majority of benign fatty tumors you see are just lipomas, and you don't have to give it a second thought. But there's a few on this list that are a bit tricky, and the one I'm going to talk about is this one, spindle cell and pleomorphic lipoma, because it's really among the most common consults we see, so it clearly causes problems. This is ridiculously rare, chondroid lipoma. It's unlikely you'll ever see a true chondroid lipoma, which is different, by the way, than a lipoma with metaplastic cartilage. That is not a chondroid lipoma. Chondroid lipoma is different and is exceedingly rare. And these other ones, some of these are relatively uncommon, but this is not uncommon, spindle cell and pleomorphic lipoma, which is why we'll talk about it. And then again, we have this intermediate malignancy category. There's only one tumor here that fits in. It goes by several names, so I want to get this out of the way. Okay, well-differentiated liposarcoma, atypical lipomatous tumor, same thing. You could use whatever term you want. I don't really have a preference. I use them both, just so everybody's happy. But this is a tumor that we'll talk about quite a bit, doesn't metastasize in its pure form, but can progress to a higher grade sarcoma, which can metastasize. And we call that what? Dedifferentiation. Okay? But in its pure form, well-diff liposarcoma never metastasizes. And here are the liposarcomas. I don't like this classification because it doesn't put things in any kind of context, and it actually has some terms that I never use. So I'm going to talk about liposarcomas in this way. And in this lecture, I'm only talking about well-differentiated fatty tumors. So I'm only going to be talking about well-differentiated liposarcoma or atypical lipomatous tumor. I'm not going to be talking about myxoid round cell. I'm not going to be talking about pleomorphic liposarcoma. Those are different patterns and belong to different lectures. I can answer questions about them, but...
So what we're going to talk about is something that we kind of touched on in the first lecture when we were talking about all this molecular approach to endometrial cancer. And I kind of conceived this lecture the same way I conceive most of my lectures is by issues that I come across while I'm signing out cases. And if you were catching the undercurrent of the first lecture, it was that, well, histology doesn't really help sometimes, and stains don't really help sometimes, and so what do we do, right? And so, what I want you to think about, and this is the kind of the way that it hit me, was you go down, you're getting through your cases, thinking about lunch, what you're going to get, or my coffee's getting kind of cold, I need to refresh it, and then you see like this. Right, you pick up the slide and you see this, and right, and what is that? And you know that you just lost that lunch time. You got to get the stains in before cutoff, and you know that the first batch of stains probably isn't going to work anyway, right? So it's that, and this is kind of what I think my resident sees in my face when I'm looking through the scope. I didn't know that anguish could be that visible, but that's probably what it looks like. And so really, how do we deal with these? And I'm going to see, look where we're going. We're going right back to 2013, right back to the TCGA. I showed you that big, horrible, convoluted graph picture chart that they put together, and we're going to delve into that a little bit. And we're going to use that to pull out some things that we can do to help navigate these cases. Right? And remember, none of their data included clear cell, and that's because everybody hates clear cell and they'd rather ignore it and pretend like it doesn't exist. So what we're going to do is we're going to use this study And the results that have come out since, that we all now have reviewed a little bit, have a basic understanding of, to help classify these cases. All right, and so back to this. All right, and so what we're going to do is we're going to pick some of these things apart. And like I said before, if you stare at this long enough, you'll learn something. Right? If you stare at it long enough, you'll learn something. Like, look over here, copy number high, serous-like. If you stare long enough, you look down here, you see this big red line, and you come down here, and that tells you it's copy number cluster 4, which means high. Serous-like, every single one of them had that. Okay, that's interesting. Come down here, look at the histology. Look at the tumor grade. Brown, it's this gray all the way across, right? You've got this purple here. They were serous and they were grade 3. Not that there's grade 1 serous in the uterus. But what I'm saying is all of a sudden these trends start to leap out and you start to see things.
Hello again. We're switching gears, moving to kidney. So this is going to be a review of a lot of entities that probably you may or may not be familiar with. So bear with me. I hope that I will make it, simplify things for you, but we'll see if it happens. I have no disclosures. So we're going to be talking about tumors with pink eosinophilic cytoplasm. Unfortunately, to break you the news, it's all of them, meaning all renal tumors may have pink eosinophilic cytoplasm, so we're going to have to discuss a lot of common and uncommon tumors and try to understand key morphologic and immunohistochemical features that can help you distinguish different categories. But particularly what I'm trying to focus is, can you distinguish tumors that have favorable prognosis, so they're going to behave in a benign fashion, versus tumors that may have more aggressive behavior? Because there are times in which you will need a lot of immunohistochemical studies or molecular to fully categorize them. So the objective is to move you from a panic attack when you have all these pink tumors to just do not panic, stay calm, and ideally, if we can categorize them, you can have more relaxed approach towards these pink eosinophilic tumors. So renal tumors represent about 2% of all cancer globally and 2% of cancer death. Now, you can see that based on the staging, of course, the 5-year survival is very different. It goes from 12% when you have distal metastases to 93% if they are localized. There's been an increase since the 1990s, and now it's become the 7th most common cancer in male and 10th in female. And this, of course, is due to imaging. Most of those tumors are detected during imaging for other reasons. And in fact, 60% are incidental finding. The important thing is to remember that at least 2 to 5% of renal tumor are associated with inherited syndromes. And these are the ones that you want to be able to, to recognize, because they will have an impact for the patient and for their families. So as you can see here now, the classification of the renal tumors has expanded over time, right? We moved from 4 different categories to a list of, 20, and this is on growing category of tumors. And you can see this is from the 5th edition of the WHO. Now, a lot of tumors have pink eosinophilic features. And you need to think about most of those entities when you look at a pink tumor. So let's see if we can try to classify them in different buckets. So these are tumors, of course, with pink eosinophilic cytoplasm, but more like they have bland